So, hello, good morning, good afternoon, and good evening to all our speakers, shares, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Japan, Dr. Ryota Tamura. Dr. Tamura is an assistant professor, Department of Neurosurgery at the Keio University School of Medicine. He had a clinical attachment at the Salford Royal Hospital, Manchester Centre for Clinical Neuroscience, UK earlier. He is a member of the Japanese Neurosurgery Society, Japan Congress of Neurological Sciences, Japanese Society for Skull-Based Surgery, and his clinical interests are mainly focused upon neuro-oncology, genomics, skull-based tumors, and neuroanatomy. He has won several awards and honors for his outstanding contribution to neurosurgery in his country, and we are extremely grateful to him for accepting our invitation to be a speaker for our webinars. And today we will be talking about approach selection and surgical planning for posterior fossa tumors. The speaker for the second session of today is our very honorable guest from China, Professor Yu Yao. Dr. Yao is a professor in the Department of Neurosurgery at the Huashan Hospital, Fudan University, Shanghai, China. He is also the Vice Chief Glioma Service, focuses on minimally invasive surgery for brain tumors and immunotherapy. He was the recipient of the Wang Chong Cheng Award of Young Neurosurgeon in 2018, as well as the Chinese Young Oncologist Scientist Award as 2016. He was a former visiting fellow at the Beth Israel Deaconess Medical Center, Mayo Clinic, Dana-Farber Center, and also the MD Anderson Cancer Center. We are extremely honored to have today to be a speaker for our webinars, and today we will be talking about benefits of DC vaccine for glioblastoma, new mechanisms, new evidence, and new technique. The chair for the first session of today is our honorable faculty from Alicante, Spain, Professor Pablo Gonzalez Lopez. Prof. Lopez is a professor in the neuroanatomy at the Miguel Hernandez University, Alicante, Spain. His practice is focused on skull-based neurosurgery and neuro-oncology. He has a specific interest in neurosurgical education and he serves as the chair for education division of the EANS. He is a former president of the International Association of Neuroanatomy. He is a co-director of 3D Neuroanatomy project, and he is an acclaimed researcher with several publications to his credit. He has gained his knowledge through fellowships by working with legends in neurosurgery such as Professor Michael Lawton, Prof. Oliveira, Prof. Fukushima, Prof. Ernest Niemi, Prof. Uyghur Ture, and Professor Yasser Gill. We are extremely grateful and honored to have him today for our webinars to chair the session of Professor Ryota Tamura. The chair for the second session of today's webinar is our honorable faculty from Indonesia, Dr. Selvi Oswari. Dr. Oswari is a board-certified neurosurgeon working at the Indonesian National Brain Center in the Tumor Division and a faculty member at Neurosurgery Department, Universitas Padjadjaran. And her interests in neurosurgery are focused on skull-based neuro-oncology with special focus on endoscopic transperineal pituitary surgery and awake craniotomy. She has completed her clinical fellowship in skull-based neuro-oncology from the University of Toronto, Canada, and also earned her European endoscopic skull-based diploma at the University of Paris. And she holds several important leadership positions, including co-chairing the WFNS Women in Neurosurgery Committee, Secretary of the Indonesian Women in Neurosurgery, and Treasurer of the Indonesian Surgical Neuro-Oncology Committee. We are extremely grateful to her for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Lee Boon Seng from Malaysia is my co-host for today. And with that introduction, I would like to hand over this podium to our first chair, Prof. Pablo Gonzalez.
Thank you very much, Prof. Racha Kuti and Prof. Yoko Kato, for always counting on me for these exciting educational events. I really appreciate it. I feel like at home when I'm with you in the ACNS webinars. Indeed, it's my great privilege to introduce our first speaker for today, Prof. Ryota Tamura from Tokyo. I've been reading his wonderful papers and going through his research, and I'm very excited to hear his talk about approach selection on the posterior fossa lesions. That is something that I'm very thrilled about, and I'm very happy to welcome you on board and looking forward to your lecture. Thank you.
Thank you very much for introducing me. Thank you very much for giving me this opportunity, Professor Yoko Kato and everyone in ACNS. And today I'm going to talk about strategic approach selection and planning for skull-based pathology. First, let me introduce myself. I am a neurosurgeon working at Keio University School of Medicine, and my field of expertise skull-base surgery, awake craniotomy, and nasal-endoscopic surgery, and ECIC arterial bypass in clinical practice, and stem cell-based gene therapy and immunotherapy and genome editing in basic research. So I focus on both clinical practice and basic research. And reaching deep-seated lesions without compromising brain integrity. First, removing bony structures that obstruct the surgical corridor that is related to the skull-base anatomy. And second, dissect the south side and fissures for safe access. This is related to the white matter anatomy, awake surgery. Today's agenda: first, efficient bone removal. Second, exploring the cerebellar fissures. The importance of bone removal in achieving an appropriate surgical corridor. The skull-base surgery involves multiple steps. For example, this is anterior transpectoral approach, and the red circle means remove petrous apex. But this green area, these steps are critical for patient outcomes. So achieve maximal bone removal quickly and efficiently. First, approach for posterior and middle cranial fossa lesions. Anterior transpectoral approach. And our hospital established ATP, this approach in 1985 by Professor Kawase, and we have since performed the procedure in over 400 patients. And ATP is done through a subtemporal corridor to access Meckel's cave and the upper petroclavian region, and this approach consists of drilling of the petrous apex through the middle cranial fossa. And ATP has evolved to a refined approach with fewer complications through recruitment of neuro monitoring, venous analysis, and CSF leakage countermeasures. And the diagnosis of patients who underwent ATP from 1984 to 2017 is summarized in this table. This table was made by Dr. Tomio, and the most common diagnosis was petroclavian meningioma, followed by trigeminal schwannoma and epidermoid cyst. And recently, the endoscopic ATP was reported by Dr. Morisako and Goto. To achieve maximal bone removal, anatomy is very important. During cadaver dissection, exposure of the internal carotid artery, cochlear, and semicircular canals is essential for understanding the maximal extent of bone removal. And exposure through extended middle cranial fossa or combined transpectoral approaches enhances understanding of the limits of safe bone removal here. And this is an example of the maximum range of bone removal. Left petroclavian meningioma, pre- and post-CT scanning. This is cochlear, this is removed bone, and opened anterior wall of internal auditory canal here. And epidural or subdural. The rate of venous-related complications, temporal lobe injury, has decreased. The venous analysis was performed by Dr. Shibao, and when the SMCV mainly drains into the pterygoid plexus through the flamenco valley, subdural drilling of petrous apex should be performed to preserve this phenobasal vein. When performing the subdural drilling, the range of bone removal in the petrous apex tends to be slightly narrower. So GSPN must be precisely identified to maximum bone removal, and your monitoring is very helpful. And this is epidural standard procedure. This is GSPN, this is petrous apex, drilling, and the dramata of the posterior cranial fossa. And this is subdural procedure. GSPN was identified by neuromonitoring and cut the dramata and dissect the posterior side of the dramata, not anterior side, and drilling the petrous apex. And head position is also important. The posterior rotation, about 15 degrees, facilitates bone drilling. And early dural exposure through drilling from the posterior side, this blue line, improves visualization of the anatomical relationships. The prevention of CSF leakage is also important. The air cells at the petrous apex typically form numerous air cells that flow into the muscle antrum. This is petrous apex air cells. This is Eustachian tube. And the superior tympanic cavity, and Eustachian tube. But some patients possesses air cells that connect directly to the tympanic cavity or Eustachian tube without passing through the muscle antrum. These types have been found to be at high risk for refractory CSF leakage. So we evaluate the risk of CSF leakage using preoperative temporal bone imaging and tailor the dural closure technique to each patient. And we do not routinely insert a spinal drain and patients are immediately mobilized after surgery. This is an example of a high-risk patient. This air cell in the petrous apex directly connects to the Eustachian tube. Case petroglycomeningioma, approach ATP, and this tumor is very small, but chief complaint, severe facial pain, and the tumor is growing. The advantage, the ATP facilitates the opening of a Meckel's cave, leading to improvement of facial pain. The ATP allows for resection of the cerebellar tentrium and may also enable radical cure. But disadvantage, relatively narrow working space, and care must be taken to avoid damaging the temporal lobe of the dominant hemisphere. A technically demanding maneuver through carries a risk of iatrogenic injury of trigeminal nerve. This is operation time and hospitalization. The cut MMA first, and dissect the GSPN and expose the Kawasaki triangle, petrous apex. And during the petrous apex, and the dura mater of the posterior cranial fossa was exposed, and cut tentrium, and cut tentrium again at the posterior side of the tumor. And the Meckel's cave was opened. This is trigeminal nerve. And the tumor was removed, including the attached dura mater. Next case, trigeminal schwannoma. Approach ATP, and the chief complaint, facial numbness, and the tumor is rapidly growing. The ATP offers the advantage of enabling broad exposure of the trigeminal nerve from its origin to the foramen. It is a highly suitable approach, particularly for some subtypes such as MP type among trigeminal schwannomas. And importantly, in most trigeminal schwannomas, tentorial incision is not required. Rather, wide petrous bone removal provides adequate exposure. This is GSPN and Kawasaki triangle, and during the petrous apex, and the matter of the posterior cranial fossa, and the tumor component of the middle cranial fossa was exposed. This is around ovale. This is the root of trigeminal nerve, and the tumor was removed, preserving the perinoidum layer. And the internal decompression was performed and the tumor was removed. This is perinoidum layer, and this is normal trigeminal nerve. Next approach, combined transpetrosal approach. This CTP allows excellent visualization of the interpeduncular fossa in addition to the upper clivus, the lateral aspect of the brainstem, and ipsilateral cranial nerves from the oculomotor to the lower cranial nerves. And this approach allows for resection of the cerebellar tentrium and may also enable radical cure. And recently, mini CTP simplified CTP by minimizing the petrosectomy was reported by Dr. Morisako and Goto. To achieve maximal bone removal, it is important to identify the depth of the sigmoid sinus at the suboccipital craniotomy site, this red circle. And it is particularly important to thoroughly remove bone around the superior semicircular canal. And while complete mastoidectomy is not necessary in actual surgery, it is important to perform it to the fullest extent during cadaver dissection training, like this. This is the fallopian canal. The case petroclival meningioma, approach CTP, and the preoperative endovascular embolization, and the chief complaint is facial pain. Advantage, this approach allows for resection of the cerebellar tentrium. The surgeon can minimize the movement while obtaining a wider subtemporal field of view, and the reduction of cerebellum retraction, and the cranial nerves can be identified over a wide area. But disadvantage, care must be taken to avoid damaging the left temporal lobe of the dominant hemisphere, and this approach may be complex and a little time-consuming. First ATP drilling of the petrous apex, and dramata of the posterior cranial fossa, and catotentrium. This is tumor, and this is trigeminal nerve, and the Meckel's cave was open. After that, the cosmetic mastoidectomy was performed. And during the bone around the sigmoid sinus, eggshell technique, and punched out. And the mastoid antrum was opened, and the lateral semicircular canal here, and during bone around the superior semicircular canal. And cut dramata from the Troutman's triangle to the petrous apex. And the tumor was removed, but passing artery was identified in the calcified tumor component, so a small amount of tumor remained. This is a remained tumor. Next approach, one-stage ATP and RA, retrosigmoid approach. The giant cerebellopontine angle, CPA tumor, extending caudally from the jugular tuberculum to the foramen magnum, can be resected using one-stage ATP and RA. The foramen magnum decompression and the C1 laminectomy can be easily added. The skin incision of one-stage ATP and RA is slightly longer than that of CTP. The bone flap is similar. The case giant trigeminal schwannoma, the one-stage ATP and RA, the foramen magnum decompression, and the C1 laminectomy were performed because chief complaint is severe headache caused by tonsillar herniation. Advantage, this approach allows for a wide field of view toward the caudal lesion. The FM decompression and the C1 laminectomy can be added in a relatively simple procedure. But disadvantage, it is necessary to compress the cerebellum, and during ATP and RA procedures, the surgeon must change their standing position. This is video, the Kawase's triangle, GSPN, and drilling the petrous apex. Dramata of the posterior cranial fossa and the internal auditory canal, catotentrium, and the Meckel's cave was opened, and the tumor component in the middle cranial fossa was exposed, and the internal decompression was performed, and the tumor was removed, preserving the perinoium layer, and the tumor component of the ATP site was first removed, and after that, the lateral sigmoid approach was performed, like this, and the tumor component of the lateral sigmoid approach site was moved into the ATP site. This is the petrosal vein, and the tumor was completely removed. This is trigeminal nerve. This is the lateral sigmoid approach site. So approach selection, CP angle tumor, for example, the petroclival meningioma, extension to the ventral brainstem, Meckel's cave, or the middle cranial fossa, no RA, lateral sigmoid approach. Yes, located posterior to IAC or around the jugular tuberculum, no ATP. Yes, caudal to jugular tuberculum or marked mass effect on the brainstem, cerebellum, no CTP. Yes, one stage ATP and RA. Next, approach for anterior and the middle and the posterior cranial fossa lesions. Endoscopic endonasal approach, EEA, and endoscopic supraorbital approach, ESOA. The approach selection, this is anterior skull-base meningioma. If the tumor is mainly located on the planum sphenoidale, like this, ESOA can be selected. And if the tumor is mainly located on the tuberculum sella and lateral extension to IC, EEA can be selected. And if the tumor is mainly located on the tuberculum sella and the lateral extension beyond IC, combined approach EEA and ESOA can be selected. But, of course, the traditional craniotomy remains an excellent approach with numerous advantages. To remove bone to the maximum extent and secure an adequate operative workspace during EEA, this is transcell approach. To create wide working area deep within the nasal cavity, it is crucial to meticulously remove the bone at front. And by focusing on the sella tussica, straightforward recognition of juxtaposed anatomical structures are obtained. This is an example of transmaxillary transpterygoid approach for trigeminal schwannoma. This is anatomical structure, midline, sella tussica, tumor, foramen ovale rotundum, V2, Vidian canal, IC. And the prevention of CSF leakage is also important. Adding multi-layers and sutures is crucial for preventing CSF leakage. Autologous dura vascularized mucosa of the sphenoid sinus, fat and fissure, and the absorbable artificial dura can be used, and the suturing technique is also important. And for high flow CSF leakage, vascularized nasoseptal flap and vascularized middle turbinate flap can be used. This is an example of transmaxillary transpterygoid approach for trigeminal schwannoma. Place small fat grafts in the Meckel's cave and large fat grafts in the excision cavity. Finally, place a vascularized nasoseptal flap. Multi-layers. The case planum sphenoidale meningioma, approach ESOA, and the tumor is growing. The advantage, the surgeon can immediately reach the tumor. Disadvantage, mastering coordination with the scopist is required. And this procedure is a burden on the olfactory nerve. The scar is almost unnoticeable. The tumor can be easily identified, and the tumor was detached from the anterior skull base. And this is optic nerve. And the internal decompression was performed, preserving the olfactory nerve. And cut the arachnoid layer around the optic nerve. And the tumor was removed. This is olfactory nerve. Next case, tuberculum sella meningioma, the approach EEA, and the chief complaint, visual field disturbance. The surgeon can resect the dura mater along the primary tumor site, and the bilateral optic canal decompressions are possible, and less damage to the frontal lobe. But it is difficult to reach the tumor component extending outside the IC. Drilling around the optic canal, right side, left side, and coagulate and cut to the matter, tumor was identified. So internal decompression was performed and cut the arachnoid layer and the tumor was removed. And after that, the cut the dura mater around the optic canal. This is ACA, optic nerve. This is fissure to prevent CSF leakage, and the suturing technique is important. Next, combined approach, EEA and ESOA. The team EEA and the team ESOA merge to form a single team like this. This is EEA monitor, this is ESOA monitor. And a simultaneous operation during surgery is possible, allowing each other to cover areas of weakness. Case 12 meningioma, combined EEA and ESOA, the chief complaint, visual field disturbance. The tumor, lateral extension beyond the IC, and the posterior cranial process, and posterior cranial fossa. An advantage adequately covers extent of progression of large tumors. And disadvantage, mastering coordination with the teams EEA and ESOA is required. And a simultaneous operation can be performed, so ESOA operator can guide the EEA operator, and the EEA operator can guide the ESOA operator. Oh, sorry. This is ESOA, and this is optic nerve, ESOA monitor. This is the EEA monitor, and the simultaneous operation can be performed. This is the SHA and the optic nerve. This is tumor around IC, ESOA monitor, and internal decompression was performed. This is EEA instrument. And guide the EEA operator. This is contralateral optic nerve. The tumor component outside the IC can be easily removed by ESOA. This is final view. Next approach, transmaxillary transpterygoid approach. Some trigeminal schwannomas can be resected via transmaxillary transpterygoid approach. The EEA is a choice for M-type and the EM-type trigeminal schwannomas. And the E-type trigeminal schwannoma can be easily resected via EEA, like this. The case, trigeminal schwannoma. The transmaxillary transpterygoid approach, and the chief complaint is severe facial numbness and tumor is glowing, and a small tumor component in the posterior cranial fossa. The EMP type trigeminal schwannoma can be removed via EEA, and since the brain is not significantly exposed, it is a safe procedure. This is advantage. And since the trigeminal nerve is not directly exposed, postoperative facial numbness may also be minimal. But disadvantage, relatively narrow working space, and the careful manipulation is a little difficult with a tumor component in the posterior cranial fossa. This is IC ceratoschica during the pterygoid process, and cut the dura mater around the tumor, and the internal decompression was performed, and the tumor was removed, preserving the perineurium layer. And this is microscope, and the tumor component of the posterior cranial fossa was removed, and a CSF leakage was identified. This is final view. So approach selection, trigeminal schwannoma, E, EM, and M type are suitable for EEA. The PMP and the EM large P, large tumor component in the posterior cranial fossa are suitable for ATP. And the EM small p, small tumor component in the posterior cranial fossa, are suitable for EEA and ATP. Next, the endoscopic transorbital approach, ETOA, and this approach has been increasingly used to treat lesions of the middle cranial fossa, such as sphenoid wing meningiomas or cavernous sinus disease. In this case, orbital cavernous venous malformation and sphenoid ridge meningioma. The exophthalmos, visual impairment, and tumor is glowing. And this patient had both an intraorbital lesion and a middle cranial fossa lesion. So advantage, ETOA enables simultaneous removal of intraorbital and middle cranial fossa lesions. The ETOA benefits from a straightforward lateral to medial trajectory, but the disadvantage, the narrow working space, and the mastering coordination with a scopist is required. The removing the bone of the lateral orbital wall is the important process of this approach, and cut the meningoorbital band, and remove the anterior crinoid process, and cut the dura mater, and the meningioma was identified. And the first meningioma was removed, optic nerve, oculomotor nerve, and the IC, PCOM. And the next orbital cavernous venous malformation was also removed. So next topic, exploring the cerebellar fissures. Approach for the posterior cranial fossa lesions, lateral sigmoid approach. This approach is most commonly used and a simple approach for the lesions located on the posterior cranial fossa, for example, vestibular schwannoma and CP angle meningioma. And the lateral sigmoid craniotomy is characterized by bony skeletonization of the sigmoid and transverse sinuses. The lesions ventral to the brainstem or cervicomedullary junction require the addition of transcondylar or fossa approach or endonasal transclival approach to create the necessary surgical corridor. This is an example of vestibular schwannoma lateral sigmoid approach. The most important procedure is to preserve perinoium layer. The tumor was removed, and this is a perinoium layer. This is an example of the foramen magnum meningioma. The transcondylar approach, occipital condyle is exposed. Draining and open the hypoglossal canal here. And to secure a large operative workspace in the posterior cranial fossa, approach using cerebellar fissure, for example, suboccipital transhorizontal fissure approach, may be one of the options. Traditional surgical approaches. If the tumor is located on the deep cerebellar hemisphere, transcortical approach can be selected, but disadvantage, damage to the cerebellar cortex. If the tumor is located on the proximal side of the CP angle, lateral sigmoid approach can be selected, but disadvantage, retraction of cerebellum. And if the tumor is located on the upper fourth ventricle, the transcerebral medullary fissure approach, infratentorial supracerebellar approach, and occipital transtentorial approach can be selected, but gaining exposure to the upper fourth ventricle can be technically challenging. This is anatomy of cerebellar fissures. This is horizontal fissure. This is MRI, and the arrow shows horizontal fissure. And horizontal fissure commences anterior to the pons and passes horizontally around the hemisphere to the midline posteriorly. The superior and the inferior semilunar lobules are divided by the horizontal fissure. No tight connective tissue is observed in the horizontal fissure. This is tracts related to the cerebellum. Horizontal fissure here. And the Purkinje cells are the sole neuronal output from the cerebellar cortex, sending input to the deep cerebral nuclei which in turn project to the thalamus, brainstem, and the motor cortex. The approach using HF, horizontal fissure, allows us to reach the deep cerebellum while minimizing the damage to the Purkinje cells. So approach using horizontal fissure, opening the suboccipital surface of the horizontal fissure to create intermediate, lateral, and medial surgical corridors, provided optimal viewing angles and wide access to the deep cerebral hemispheres, CP angle, and the upper fourth ventricle, without heavy cerebral interaction. And adequate exposure of deep cerebral lesions is achievable without compromising neuronal structures or relying on skull-based approaches. This is lesion in the deep cerebral hemisphere. The horizontal fissure of the suboccipital cerebellar surface is dissected above the pathological lesion as widely as possible to allow complete resection. This is intermediate corridor. The large and deep-seated pathological lesions can be removed without aspiration of the cerebellar cortex or deep white matter. This is dentate nucleus. Lesions located proximal to CP angle. A previous study demonstrated that dissecting the petrous surface of the horizontal fissure is useful for microvascular decompression surgery to reduce tension on the vestibulocochlear nerve. And in our study, the horizontal fissure was fully opened from suboccipital surface of cerebellum. After the lateral side of the horizontal fissure is opened, a spatula is inserted to gently retract the superior and the inferior semilunar lobules toward the CP angle. This is the lateral corridor. The lateral corridor provides adequate access to the proximal side of the CP angle. Lesions in the upper fourth ventricle, the opening the horizontal fissure and creating a medial corridor can expose the superior medullary velum. After penetrating the superior medullary velum, all structures within the upper fourth ventricle, including the aqueduct here, can be directly seen. And the medial corridor provides a direct, flatter plane to the upper fourth ventricle and the brainstem. This is sagittal view, pharynx cerebelli, and upper fourth ventricle. So cerebellar fissure and horizontal fissure. The transcerebellar fissure approach has always been the neurosurgeon's preferred approach in order to reach deep-seated supratentorial pathologies because of its feasibility and simplicity. And analogous to this everyday surgery approach, this suboccipital transhorizontal fissure approach, SHF, may also become a generally applied approach to reach deep-seated posterior cranial fossa lesions. So corresponding structure, the frontal lobe, superior semilunar lobule, temporal lobe, inferior semilunar lobule, and the basal ganglia, dentate nucleus. Are there veins within the horizontal fissure that may obstruct the corridor, like cerebellar vein? The venous anatomy and the cerebellar structures surrounding the horizontal fissure relevant to the suboccipital transhorizontal fissure approach were analyzed using MRI and CTV. This analysis was performed by Dr. Sogano. Red structure, target vein subtype, the inferior hemispheric vein, the transverse sinus, the petrosal vein, the SPS, VGHF, and the D type, this horizontal vein type, the distinctive veins running horizontally along the horizontal fissure, like cerebellar vein, observed in 24% of hemispheres, also act as potential barriers during wide HF opening. The VGHF should be secured on the lateral side of the horizontal fissure. The inferior hemispheric vein should be peeled from both lobules and moved laterally to obtain an adequate operative field without sacrificing of venous return. The case metastatic brain tumor, The MRI demonstrated an enhancing lesion in the left cerebral hemisphere with surrounding edema. The lesion was located 25 mm from the brain surface. The surgery was performed using the intermediate SHF approach. The gross total resection was achieved without needing to aspirate cerebral cortex or deep white matter. So surgical tract is unnoticeable after the operation, and no cerebral cortex or white matter damage is present. First, dissect the horizontal fissure and make surgical corridor above the tumor, and the tumor was completely removed without aspiration of cerebral cortex. Next case, exophytic brainstem glioma, the lateral SHF. The lateral SHF has been previously used for microvascular decompression. In this case, complete opening of the lateral horizontal fissure was performed to reveal the proximal portion of the brainstem. This is brainstem and this is tumor, and this is microscope direction through horizontal fissure. In the next case, cerebral hemorrhage, hydrocephalus. The hematoma within the third ventricle was also removed. The reaching the third ventricle was confirmed using a navigation system. So first, intermediate SHF, removal of cerebral hemorrhage. And after that, medial SHF, removal of the hematoma in the third ventricle through aqueduct. So hydrocephalus improved without performing external ventricular drainage. This is a horizontal vein type, and dissect the horizontal fissure in the first intermediate SHF and remove the hematoma in the cerebellum. And after that, the medial SHF was performed and dissect the penetrating the superior medullary velum, and the fourth ventricle was identified. So remove the hematoma in the fourth ventricle first. And after that, this is aqueduct, the irrigation irrigates in the third ventricle and remove the hematoma. The surgical corridor is 1 cm patty. So reaching deep-seated lesions without compromising brain integrity, first removing bony structures that obstruct the surgical corridor. Second, dissect the sulci and fissures for safe access. Suboccipital transhorizontal fissure approach may be one of the options. So thank you very much for your attention. This is acknowledgement. Thank you very much.
Thank you, Prof. Ryota. That was an excellent overview, indeed, of not only skull base, but also intrinsic posterior fossa lesions. And what I really liked is the way in which you conducted the talk, as you were mainly highlighting very important aspects, different steps during surgery. And what I really liked is that you gave great importance to complications avoidance while during the approach by itself. You can do a fantastic surgery, complex approach. I saw the time, 10 hours, 8 hours, 9 hours doing your surgical approach, and then having a CSF leak is terrible. So I really like the way in which you were predicting and how to try to avoid these complications. On the other way, you also show different combinations of approaches, anterior, posterior, transpetrosal combined, how you can combine those with the retrosigmoid approach. And I think this is the way in which people who are listening you are getting tools. So getting tools is widening our view of the same disease. And this is what I believe it's education. So thank you for that.
Thank you very much.
I belong to a school in which I've been trained on trying to do more with less. And I'm very, very fan of the retrosigmoid approach that you went through very nicely. But I have a question regarding let's say, these small petrous apex meningiomas. Even whenever they don't grow, they cause neuralgia or this is tedious, uncomfortable, and you have to do surgery. Radiosurgery, I believe, is not an option. And I have always thought that even with the retrosig, and this is what I do, indeed, retrosigmoid approach, despite the fact that the tumor is just anterior to the trigeminal nerve, I find it very easy, safe, fast. I want to know which are your thoughts about the retrosigmoid approach for this small. I'm talking about the small petrous apex meningiomas.
Okay, thank you very much for your question. And if the patient has a small size tumor on the petrous apex and the facial pain, first medication. But sometimes medication leads to Tegretol, leads to the dizziness of the patient. For those patients, I recommend surgery. And the surgical approach is, for me, anterior transpetrosal approach, because some petroclival meningioma extends into the Meckel's cave sometimes. And open the Meckel's cave, release the pressure of the trigeminal nerve. So leads to the improvement of the symptom of the patient. So for me, the anterior transpetrosal approach is the first choice.
Okay, that's very good to know. And there is also a maneuver I'm sure you are very aware about. I mean, your school is fantastic for anterior transpetrosal, but in other parts of the world, for us, is a very complex approach, complex skull-base approach. That's why I want to share that even with a transsuprameatal tubercle drilling through the retrosigmoid, you can even reach not as nicely and widely, but that could be an option. And just wanted to share that too, and I really appreciate your answer.
Yes. I think so too. The suprameatal tuberculum by the retrosigmoid approach is good option. But I'm afraid of the petrosal vein around the tuberculum. Yes.
Drilling around it.
Yes.
I fully agree. And one thing that your approach, your anterior transpetrosal approach, is very good for is that you are reaching a complete resection. You are drilling the bone, you are removing the dura, even before you start touching the tumor. So, but by all means, this is, let's say, the most efficient way to remove a meningioma and with anterior transpetrosal. Yes. And which are your limits for the anterior transpetrosal when you are dealing with a petroclival tumor? Which are your, let's say, lower limit? How do you see that?
I think the lower limit of the anterior transpetrosal approach is jugular tubercle, and the posterior limit around the internal auditory canal. If the tumor is extended into the lower part, retrosigmoid approach is the best.
Okay, very good. And let's go again for young neurosurgeons, who are you and me, about the learning curve. I mean, you are finishing your program and you want to jump into the skull-base program. You want to do skull-base surgery. And there is one day in which you have to jump into the pool and do this approach. How or which is your suggestion for those young people who don't want to do these skull-base approaches, and how would you recommend them to start performing this? What kind of tumor you would recommend them to start with?
Oh, for young neurosurgeon.
Yeah.
Okay. Small size petroclival meningioma is a little difficult. So trigeminal schwannoma is recommended. I recommend trigeminal schwannoma because importantly, the temporary incision is not required for most trigeminal schwannoma. So if the young neurosurgeon try to perform operation, trigeminal schwannoma. But young neurosurgeon needed to perform training through the cadaver dissection and the 3D printer and other devices. Training is very important.
That is for sure, and I fully agree with you. Education in the lab, cadaver lab, and printed models is very, very relevant. But sometimes, even when you are super ready in the lab and you think that you can do, you have to do. And I like the answer you gave. Trigeminal schwannomas, I like that also, because you don't have attachments to the meningeal structures. These are usually less bleeding tumors and you can control better. And some of them have done kind of petrosectomy for you. So I really enjoyed the answer. So I don't know if I cannot see any Q&A. And
so far none, but I would love to ask several questions.
Okay.
So going to thank you. So first of all, let me congratulate Prof. Tamura for this wonderful lecture. We learned a lot, and your school is of course a very famous school. Professor Takashi Kawase who's the founder of this approach, anti-transpetrosal approach. you have done more than 400 cases. Is really wonderful. But one philosophy that I would like to share that about drilling of bone, there was a discussion between retrosig and anti-transpetrosal for anterior placed lesions. So having spent some time with Prof. Goto, I would like to share his philosophy that bone drilling is the main thing in the petrosal meningiomas, because they derive the blood supply mainly through these channels, bony channels, small arteries from the bony channels. So once your drilling is complete, the tumor changes its texture and also the color. It becomes more deep brown when the vascular supply is cut off, and it becomes very friable. So that drilling is very important. And about the CTP, I would like to mention that you did not stress upon what you do with the endolymphatic sac. What is your preferred approach method for dealing with the endolymphatic sac?
For large tumor, I cut the endolymphatic sac because I need more wide view through the Troutman's triangle. But the relatively middle size tumor, I preserve endolymphatic sac.
Yeah, okay, thank you. So current new article from Zurich came out with the, and not only Zurich came out with the subdural subdural Kawase, and also the endolymphatic sac preservation approach for CTP has come from none other than Sebastian Felic et al., who's devised another method to preserve the endolymphatic sac for CTP. And for the CSF leaks, like Professor Ohata's method of taking a pedicled facial graft based on the sternocleidomastoid, it's always preferred over along with fat graft. So what method do you prefer in after the CTP to prevent CSF leakage?
To prevent CSF leakage.
CSF leakage.
Yes, I use fat tissue, but how to put fat to the mastoid is very important. Not the large size. Put small size fat again and again and again. And last, finally, to put large size fat tissue.
But a small difference between what you showed and what Professor Goto Sensei does is like the bony work is first completed.
Yes, Dr. Goto.
Goto Sensei does it, but you opened the Meckel's cave first, exposed the tumor, and then you came back to mastoidectomy. So that is a small difference between Osaka and Kyo, I think.
Nevertheless, yes, mini CTP.
Yeah. Nevertheless, it was very interesting. We learned a lot. Thank you very much. I would like to give back the podium to Professor Pablo. I can see Selfie here. Prof. Selfie, can you hear us? Selfie, yes, legendary skull-based neurosurgeon having fellowship from both Paris and what is your opinion, your comments, please?
Yes, thank you very much, Raja. That's a very nice comments on you. So I would like to congratulate Professor for the impressive lecture. I actually have a question regarding you are mentioning the trigeminal schwannoma, taking from the transpterygoid and transmaxillary approach, and then you can also do it from the lateral approach, either the anterior transpersal approach. Would you have any suggestion in which lesion you would choose one over the other, Professor?
For trigeminal schwannoma?
Yes.
Okay. Based on the Yoshida classification, EMP type and EM small p type. Small p means the small tumor component in the posterior cranial fossa. I choose the transmaxillary transpterygoid approach because the facial numbness after surgery is minimal for the patient. The ATP has very great approach, but trigeminal nerve is completely exposed. So some patients feel facial numbness after the surgery. But the tumor component, large tumor component in the posterior cranial fossa, ATP is the best. or the endoscopic ADP. And recently the transorbital approach. Yes,
Can also reach.
So the comparative analysis among the transorbital approach and the nasoendoscopic approach and the craniotomy is needed.
Thank you. Thank you for the excellent explanation. Thank you, Raja.
Thank you, Selfie. So we'll go back to our chair to hear his concluding remarks. Pablo.
Thank you, Raja. And just to conclude, I also want to highlight the beautiful paper regarding the transhorizontal fissure approach that I read even before I was assigned to chair this session, and I really enjoyed it. It's a wonderful, again, providing tools for intraoperative management. And I just want to, again, congratulate you, Ryota, for your excellent work and for sharing your expertise and your tips and tricks for these complex skull-based approaches. Thank you very much.
Thank you very much.
So thank you, Prof. Pablo Gonzalez and Prof. Ryota Tamura for the wonderful session, and we thank you for your time and support for the ACNS webinars. I would like to mention that this has been broadcasted on WeChat, YouTube and Zoom, and as of now we have around 458 people who have logged in through all the different channels, so we are extremely grateful to Professor Shubin for that. So we'll move on to the second session. I'll give the podium over to Prof. Selfie Aswari to take over.
Thank you very much, Raja. Thank you for the opportunity. It is a great honor for me to introduce Professor Yu Yao, which today he will be talking about the benefit of dendritic cells vaccine for GBM, the new mechanism, evidence, and technique. As we know that the dendritic cell vaccine have been investigated for the last 2 to 3 decades and through the clinical research, but has not been yet becoming one of the standard of care. It will be very interesting to follow Professor Yao's presentation regarding the new advancement on the dendritic cell vaccine. Professor Yao, please, the time is yours.
Okay, thank you very much for Selfie and Modit. So today my topic is about dendritic cell vaccine for GBM, new evidence and a new mechanism and new technology. And I'm Dr. Yao from the Department of Neurosurgery, Hua-Shan Hospital, Fudan University. So it's very happy for me to present this topic. So we start from the medical background. As we all know that GBM is still now uncurable. GBM is the most primary brain cancer, and we know that for new diagnosis GBM, the patient survival is about 18 months, and with 5 years survival less than 9%. And recurrent GBM, the people will survive very less, about 6 to 9 months. So by now we know that there are some chemotherapy such as CCMU, BCMU. In 1980s in America, we found that this drug is very useful, and I think 20 years ago that temozolomide is discovered. Then temozolomide, this CCMU is for the GBM. Then 2009 we know that Avastin is also can reduce the edema, and 10 years ago we know that TT field in China, TT field will cost about 500,000 RMB every year. So for the GBM is also the operation, radiotherapy, and chemotherapy and targeted therapy. So because the overall is very less, so we need new treatment ways. So dendritic cell, most powerful and professional antigen present cell, is discovered in 1973. This cell is the key to development T cells response. As we know, infiltrate cells that reside in the most tissue, where they sample the antigen, but if they activated by the antigen, like the tumor treatment by the radiotherapy or chemotherapy, or the I think the virus or the peptide or we will talk about the glial stem cells lysate later. In the tissue, they migrate to draining lymph node. Then active DC peptide will process from the antigen material take up on the human lysate antigen. The antigen-specific T cell, we know that is TCL, and the TH recognizes peptide, get active, proliferate, and different to the affected cells, which exude the cellular adaptive immune response, including the killing the target cancer cell. This is the figure that illustrates the mechanism. So this is the DCV is the first evaluated in the 1996 in the clinical trial for B-cell lymphoma. This is the process. This is blood, the fissure blood. Then we isolate the CD14 positive monocyte. Then after, I think, 1 week, they can change into the DC. Then antigen load, including the peptide or the protein or the DMA, RNA, or the new technologies such as mRNA and lysate tumor cell, then can to the material, then deliver to the people's body. So the first very successful for DC vaccine is the Progen. That was the first one, and so far the only one, the DC vaccine approved by FDA in 2010. So the key word for the DC mature is the TSA or TA. That's very important for different tumor or cancer mode. So there is no other vaccine approved yet. As we know, UCLA Professor Linda Liao in 1999, he first documents the DC vaccine in the rat glioma model. Then, after 1 year, she performed the first DC vaccine treat case. And in the 2022, his group published a paper in the journal Oncology that shows the benefit of DC vaccine both in the new diagnosis and recurrent GBM. So after then, I think there are, we just learned in the lecture there are more than 1,000 patients have been vaccinated in this world. So this patient is all safe. So we showed some data of our DC vaccine in our clinical settings. About 20 years ago, we first do some research about the glioma stem cell. We found the glioma stem cell is very important, both in the tumor growth or recurrent or resistant to the radio or the chemotherapy. We isolate the glioma stem cell first. Then we found that if the glioma stem cell lysate, they can induce the DC mixture and more immunological compared to non-stem cells. And if we use the A2B5 stem cells, that will got more amount and powerful antigen from the A2B5 cells compared to the CD133 positive stem cells. And this kind of lysate can induce the DC cells to mature and to introduce a signal to the T cell that will cause more ability to kill the cancer cell, both in the CD133 positive or negative cell. And in the animal model, we found this kind of the DC vaccine is very powerful and can significantly prolong the oath in the mice animal model. Then in 2011, my boss, Professor Liang Fuzhou, carry out the first DC vaccine in China. We just enrolled 5 cases, and we found one case is have a PR, and the side effect is very mild, just a fever or local pain due to the injection. And the 5 case will get the 18 months for the recurrent case, and this is after the sorting the CD133 positive percent. But we found the shortcoming that CD133 case is cells in the recurrent glioma is very less. We can show the percent only 4.36, and less than, most is less than 10%, and this case is more than 20%. So we found that the CD133 is less. So that means we just get a very low antigen dose. So in 2018, we just use A2B5 cells, irrigate the DC vaccine for GBM. We used 2 arms. 1 ounce is a placebo group. After resection, we just use radio and chemotherapy. The other DC group, we aside with radio and chemotherapy, we also use the DC vaccine. That's the process: surgical resection and glioma tissue culture and A2B5 cells culture and lysate. And then we got the antigen, then injected to the ID model, then to treatment the GBM. So this 2-arm blind, we found that this is corrected clinical. We found both in all the case, both in new and recurrent, we found the DC will prolong the OS about 14 months plus the 11 months. And especially for the recurrent GBM, we found the benefit is very significant. We can got the 17 months compared to 7 months. So as we know that TT field for the recurrent glioma, they got the data about 6.6 vs 6, and the DC vaccine also have almost twice benefit. So we found that the recurrent GBM may be more fit for the DC vaccine. So this is the third clinical trial. We just use combined treatment. We combine DC vaccine with PD-1 antibody for recurrent GBM. This kind of GBM is also resectable. Before the operation, we just use a new adjuvant with PD-1, then operation. And one group, we get the tissue to get the DC vaccine. And after operation, about 1 month later, we use DC vaccine plus PD-1. And the other group is just the PD-1. This is the enrolled standard, including 18 to 17 years, male or female, and survival expected to more than 3 months, receive radio and chemotherapy before. First pathology is ID wild type GBM, and no other trial in the recent 30 days, no normal organ function, and no steroid or minimal dose, and no antibiotic drugs in the recent 3 days. We use contrast MRI scan in the 72 hours to evidence the total remove or most part remove the tumor. And the tumor finally was evidenced by the pathologist for recurrent GBM, and DC vaccine is ready. And this is for all the eligible patients. We enrolled 21 cases, 10 cases for for combined treatment, and 1 case is 10 cases for just PD-1 case. We found the OS is about 1 year. And we found the vaccine and combined PD-1 will prolong OS. That's the curve. And this is the case. You can find this is a right front and insular case. When we resect here, and we found we use stimulate and found this is this function area. Then we stop the operation, and after that we use just the PD-1 and vaccine. We can found cycle 8, and from cycle 7 we can found the enhancement is disappear. We also use this tissue to evidence that GBM. When we got the cephalic blood, we culture with the tissue lysate, we can find the very specific antigen target direct delay type hyper density. We call the DTH reaction in vitro. If the level is more than three times, we can find the patient will got a very beautiful protection from the GBM. And this is the other case. We found the tumor. We just use a vaccine, and after the vaccine, the tumor recurrent again. Then we take the tissue again. We found that there is not an incomplete DTH, just in the PD-1 case. And this is the other PD-1 therapy, not with the DC vaccine. We found that the tumor will, the blood will got not any protection effect. They just load the similar as the baseline, and the tumor will grow very quickly. So the side effect is very mild, and that shows the PD-1 and the DC vaccine is well tolerated. We can see the RCCEP or the steroid hypothesis and the fever, but most is very mild, just grade 1 to 2, no more than grade 3 to 4. This is our clinical procedure. We first do the MR scan and prepare for the vaccine. Then I do the operation, then get the tissue, then use stimulate during the operation, then GMP laboratory to produce the vaccine. Then our nurse team will inject the DC vaccine. So there is a lot of mechanism. We just talk in the cancer research in 2008. That's a very typical and wonderful paper that shows the vaccine enhanced the type 1 cytokine response. That was first in the first report in the phase 2, and we can find they just use a very useful qPCR. You know that these days we can use ELISpot or CTL immunspot to get this data. But very interesting, more effective. That paper shows more effective and response in the new GBM. I think this is reasonable, because in the recurrent GBM, the TEM, the tumor microenvironment, is more inhibited. So for the GBM, I think new diagnosis is more fit for the DC vaccine, because the patient will have enough immune level. And the post-vaccine chemotherapy induce longer survival. That's also very interesting because nowadays we also design for the DC vaccine with the chemo for the temozolomide. So this is a very good case. Now we use the glioma model in human T-cell reconstructed mice. We call the WHO PBMC. That we found that if the PD-1 antibody combines the DC vaccine, we can show the tumor is smaller. And we also use a PET scan in the animal model. We can find the combined, we got more T cell, especially for CD8 positive T cell in the brain, also in the severe lymph node, also in the severe lymph node, also the actually lymph node. And we also do some single cell sequence and found a very interesting data that effective cell will transfer from blood to the dural, then dural to the tumor. That is very, very interesting. So we also want to talk about the cell dose and the vaccine schedule. That's a very interesting paper published by Linda Liao and other authors in 1999 and 2011. The initial DC dose report to elicit T cell response in head individual is 1.1 million DC. And the Linda Liao just found that the amount of the dose of the DC vaccine with 1 and 5 and 10 million. That's very interesting. Just 1 million DC is cost very longer, actually very longer survival in the GBM. I think this is very interesting. And the optimal DC dose is difficult to define because it may need to determine on the case-by-case basis for each vaccine strategy and other factor. So the vaccine schedule, there are some very interesting. Many studies use the prime and booster vaccine approach, and better survival may receive more vaccine. Just as the case we show in the first time, for the first case, we just use cycle more than cycle 8. And admittedly, by weeks and months, there are new data that 1 week can use 3 or 4 times. DC vaccine frequently emitted into the standard care between the radio and the chemotherapy and adjuvant temozolomide, or in the case of adjuvant temozolomide cycles around day 21, some evidence and others. We can use 3 ways, IV, SC, and ID, but I prefer the more can use the ID, even more DC reach the lymphocyte. So how the DC cells work in vivo? DC can be inactive in the lymph node 3 minutes after the injection, abnormal after 8 hours, and persistent for up to 2 weeks. Only 5% injected DC may reach the lymph node and is sufficient for effective de facto anti-tumors immune. So most DC remain in the injected site, rapidly became apoptotic and clear with macrophage. So the life of span deficit in lymphocyte is limited to a few days, then apoptosis and cleared by macrophage. So in fact, there is only a little disease. So there is a lot of new ways to change that. So the most important, I think, is for DC vaccine treatment is the GBM antigenic target. Because the GBM is a very low frequency new antigen, we call the GBM very cold. In our paper, we found that GBM, there is some immune type very super cold. So more than 85% contain only up to 10, we call the TMB, so it's very cold. So for the new antigen for GBM treatment, I think is not reasonable. So in the world, there is two ways. The one way is the whole tumor cell source of TAA, also including the cancer stem cell. They will cause the antigen is diversity and cause infectious CTL response. But there is first a very low content for TAA, and the immune separate factor in the tumor tissue modify and reduce the function of the resulting DC. The other way is molecular defined TAA, such as specific peptide, protein, and targeting, and also the new ways of mRNA. They can specific response can be easily monitored, but multiple to the defined TAA to reduce the risk of the TAA loss and the violent escape. So we just think about how to mix the two of the above, because in the animal model and 173 cancer trial, including melanoma, lung cancer, the effective for the whole tumor cell source is wonderful compared to the just the molecular defined TAA. So because there are a lot of sample in Huashan Hospital, we use a new Cerex pressure. The step one is to isolate the A2B5 cells, and the second is isolate mRNA and contrast rebind CDMA library. Then the third, we expel the protein in the EQ, then blot onto the membrane, then incubate the patient autogenous serum, then add the MA inject the secondary antibody color development and pick the positive clone, then sequence. So this procedure is very complex, but finally we found just one TAA. Then we use another sequence. We found the other TAA. So we now set up the two new TAA antigens, and this antigen we use AI to modify and found that's very useful for the new technique, and this will induce more memory T cells immunity and increase the ratio of CD18 memory effective T cell. And in the animal model, we can see here, we first implant the GL161 cells to the mouse brain. Then we use DC PBS every 3 weeks, then monitor. This is one group. The other group is we use erected A2B5 positive DC. And the third, we use peptide DC. And the fourth, we use combine the peptide and the lysate. And this is we just use peptide pore first, because we just modify the clinical setting that after operation maybe cannot produce the DC vaccine properly and in time. So we use peptide DC first, then DC combine. And this is we just not use the vaccine at the first time after operation. That's the delay. Use DC combine. So in this 1, 2, 3, 4, 5, 6 group, we found a combine is very wonderful, and early use vaccine is useful. And the new technique can facilitate T-cell interaction against the negative tumor environment. So we just want to show our clinical trial in the future. That is some key message for DC vaccine treated GBM. One is we need to very wonderful and maximal surgery before the DC vaccine. We need to a state of minimal residual disease is a more beautiful benefit, because the immune suppression, which is plummet in the GBM, correlated with the tumor size. So that's also the effect that for the recurrent GBM, the immune suppression is very severe. After resection of radio and chemotherapy patient in the state of the minimal residual disease, which is benefit for the immunotherapy because the low tumor load and deplete the supplement cell. And there are two phases. And the steroid, I think, need to the very low dose, need to excuse. And more cycle is very important. Besides the MR scan, blood test for the tumor lysis and CTL immune support is also important indicate for the DC vaccine. Because the mechanism of the immune suppression in the GBM is very complex. We can know about the MDSC and the Treg and the GBM cell, and interferon is very decrease in the CTL, also the microglia. So there are many reasons and many cells in the GBM TEM. But very interesting, because the DC vaccine is very safe and minimal side effect. We can imagine that in the future, combined treatment strategy, we can use the DC vaccine as a very base treatment after operation. We can use, we just show some case with the PD-1, and we can also use together with the radio and the chemotherapy, and also other cytokine inhibit, and with the TT field or with the radio or with the reduction. So the DC vaccine is a very baseline treatment. So our department have the future plan. We will initiate our RCT, International Multiple Neurosurgery Center for new diagnosis and recurrent GBM. And we just found design to in China or in USA or in Japan or all the some Asian country. If you have interest in, you can email me.
Thank you very much, Professor, for a very excellent and thorough explanation. I understand that because of the interest of time, that's why I think you can actually still have more longer presentation, because this is very interesting and very promising. I have a couple of questions before we start with the audience. And and I have the opportunity to last year during the ASNO meeting, I visit your hospital, Huashan, which I must say may be one of the biggest neurosurgery center in the world. Congratulations, with I think almost 200 neurosurgeons in the in the hospital itself. I think it's very impressive, and it's very good
Very
that
big
I
group.
yes, very big group, and it's very good that you have a very dedicated subdivision group, which then you can explore more and hopefully can contribute to the neurosurgery world, just like what your presentation has mentioned. So I think, is it okay if we go back in a couple of basic in this dendritic cells vaccine? You were mentioning that what you are explaining in the presentation is the IDH wild type. Is there any reason why you wouldn't use the IDH mutation patient instead of the only the wild type?
Because uh, my 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 American boss, you know that Appr Young or Patrick Wen, they just found a very new drugs for IDH inhibit. So I
Uh-huh.
think the IDH positive, they have many choice, including radio, chemo, and inhibit and target cells.
Positive.
But IDH wild type is very difficult to treatment. So Professor Zhou want to set up a vaccine, combine other treatment to treat the wild type GBM.
Okay, thank you, Professor. And you are using the overall survival instead of the PFS. Would you mind explaining why the overall survival was the one that you are measuring and not the PFS? The progression-free survival.
I cannot understand because maybe the signal is a little slow.
Sorry. So in all your data, you mentioned that the overall survival is very impressive, but I haven't seen the progression-free survival in those data. Do you think
Okay.
it affects more in the overall survival instead of the progression-free survival for the vaccine?
I know your idea because the third clinical trial we just enroll the recurrent GBM, and for recurrent GBM the standard S is more important than the PFS. For the new diagnosed glioma, maybe the PFS is important and more feasible.
Okay. And regarding the timing of the vaccine, I think you mentioned that it's after the radiation before the continuous adjuvant temozolomide. Because as we know that temozolomide will also affect and suppress a little bit of the immunity, what do you think it will affect the time base that you are using right now?
I think the most important is after the radiotherapy, you need to fast fascination because that window is very precious because the very low TMB and very low tumor burden. That is very interesting and very important for the vaccine. So at that time, just after the radiotherapy, you need to I just imagine that 1 week we use 3 to 4 vaccine. If we can get enough the DC cell, that's very important. And after that, you just began the chemotherapy with temozolomide. You can use 1 to 2 for 1 month, and you can use 1 day 1 to day 5 use temozolomide, and after 2 weeks, you know that 2 weeks the temozolomide side effect is disappear. Then you can use vaccine. So that's the combine, and also the data shows the 2008 in the cancer research, the journal. The California scientists that just found that temozolomide combined vaccine is very wonderful and very effective.
Okay. And how about the the reason why you choose it to combine with the PD-1? Because there are also other agents, or what would you think if only the vaccine itself without any adjunct or other medication?
Yeah, so vaccine is very safe and very safe when combined the PD-1, which is just found the side effect of PD-1, no side effect of the vaccine. So vaccine can combine other drugs, including chemotherapy, PD-1 or CTLA-4 or CAR T. I know some places they just the together, and you can see in the Australia there is a demonstrated case in Australia. They just use two ICI and the checkpoint inhibit and with vaccine. The mechanism I think is the vaccine induced by the lysis of the cancer cell. They can induce a specific anti-glioma protection effect, but for the PD-1, they just cause not specific. They just the whole system increase the immunity, not specific. So we need to specific the immunity and with the PD-1 and other inhibit checkpoint inhibitor. That's very maybe more reasonable and more powerful. But this just my point for the recurrent GBM. For new diagnosis GBM, we can just use a vaccine. That found some data if we can do together in future.
Yes, I think that is very interesting. If we can move even further back before it recur, we already introduced the vaccine itself. So before we continue our discussion, is there any question maybe from the panelists?
Can I ask a question?
Yeah, please.
Okay.
Oh, yes, please.
Okay. Oh, thank you very much for your wonderful presentation. And I have one question. As you said, the tumor microenvironment of glioblastoma is immunologically cold, and the bevacizumab is known to change the tumor microenvironment from cold to hot and suppress some immunosuppressive cells. So how do you think about the combination therapy using a DC vaccine and a bevacizumab?
So the environment we just divide the GBM to four immune type. One type I published a paper I think 3 years ago that is a very high level on B7H4. That's a very new checkpoint inhibit. In that immune type, there is almost no T cell in the tissue. So GBM is very cold, and the very less new antigen. So just not like the other cancer type, such as lung cancer, they will have a very high TMB and a very more new antigen. But for the GBM, we must use tumor lysis, not for the new antigen, because the tumor lysis they have a diversity, and for the tumor we also do some research about the EGFR positive lung cancer will transfer the brain metastasis, and the neurosurgery we have a lot of case for the brain metastasis from the lungs cancer. For that kind of tumor, the TEM is very hot. We can find a lot of T cell, and I think the treatment is very different.
So how about the use of bevacizumab anti-VEGF antibody changed microenvironment cold to hot?
Like the drug Avastin.
Avastin, yeah.
Yes, Avastin, yes.
Oh, we have published a paper that I cooperation with the Professor Zhang from NIH. We found that after several Avastin use, then the tumor in growth, then we take out the tumor, we found the signal of the HIF2 increase very quickly. that will cause the tumor disseminate to or spread very quickly. So in my opinion, or in my clinical setting, we will use the Avastin very in the late time. Have you found that if for the recurrent glioma, when use Avastin with Cerebellar or radiotherapy, you will find a very local control rate for the GBM, but in other side, the tumor cell will transfer the other side. So I think the Avastin in my clinical setting, I will use in very late time, not for the neuro-oncologist from MD Anderson, they published a paper in the 2005 in the new diagnosis with the radio and chemotherapy, then use Avastin. They just get no benefit for OS and no benefit for the PFS. But in the recurrent, they got the positive data. So in my opinion, I will not use the Avastin in the early for the recurrent GBM, just for the late time.
Even after the dendritic cell vaccine, Professor?
We just enroll some case, the patient is failure to the Avastin, then the tumor grows, then we take out the tumor, then do the vaccine treatment. Also get some positive data.
And I think you also mentioned about repeating the vaccine itself. How would you think, in the timely basis manner, or depends on the growth of the tumor itself to repeat the vaccine?
If the failure to the vaccine, you mean that?
Yeah, to repeat. Because the dendritic cell.
I think if the patient is failure to the vaccine, you maybe think about the antigen shift, because just the lung cancer, we can find the antigen shift. Then you need to combine treatment, vaccine with chemotherapy and vaccine with. But I think the vaccine is the important role for the vaccine is prevent the recurrence. If the tumor is come back, we can use the law of neurosurgery. We can use the operation, and we can use the radio, and we can use the Avastin. But just like the TT field, we cannot use the TT field when the tumor is very large. I think that's not reasonable. If we want to use the TTF after the tumor is come back, we need to do first operation or the second radiotherapy or the Avastin, then use the TT field. I think the immunotherapy is just like the TT field. They have some the same direction, or the some we will take the effect will for some time, not quickly.
Okay, Professor Yao, thank you very much for a very thorough discussion. Yes, I congratulate you once again regarding this dendritic cell vaccine. Hopefully, especially when you already presented that even if compared to the TTF itself, it's actually having more longer overall survival compared to the TTF. Hopefully, the multi-center clinical trial can be happen in the near future, and then hopefully can bring a lot of advantage new for the neurosurgery field. Thank you very much, Professor Yao.
Thank you.
Back to you, Raja.
Thank you very much, Prof. Yao and Prof. Selfiaswari, for this wonderful discussion. Thank you, Prof. Ryota Tamura, for joining in the discussion as well. So now it's time we'll close this officially, and I'll do this. Well, on behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kato, I would like to thank both the speakers of today, Dr. Ryota Tamura and Professor Yu Yao, as well as the chairs, Prof. Pablo Gonzalez and Prof. Selfiaswari, for the time and support for the ACNS webinars. A special thanks to Professor Shubin for broadcasting this webinar today on the WeChat channel, and as I mentioned earlier, we have around 458 people who have joined in live through all the different channels. So until we all meet online tomorrow, it is bye bye from all of us. Thank you very much for joining.